Hello, it's the AEMT lecture series. Welcome back. This is going to be video number 2 for chapter 36, Pediatric Emergencies. Glad to have you. Welcome. We will go over to where we left off, and we were talking about the history and collecting history and being observant to your environmental conditions. All right, so children are not the small adult. Okay, that's why we have the pediatric triangle. That's why we have different assessment techniques. We're going to do it differently than we do small adults. Always remember the parents or the guardians. Please, please, please do that. Communicate with them. Also, be honest and communicate with the patient. And let's don't separate them unless we just have to. All right, unless we just have to, we're not going to do that. And just some common, kids concepts here. Kids know more than what you think. Watch for the hidden body language. All right, let's pay attention to it. They'll tell you they're not hurting when they're hurting. So watch, if they're having abdominal pain that they're denying, watch and see if they're guarding their stomach. Look for signs of pain in their face. Always try to talk to them at their level. Don't tower above them. You won't get anywhere with your patient because you're scaring them. Always tell them your name because they know their name and they want to know your name. So tell them who you are and be respectful to everybody, not just a pediatric patient, but be respectful to them. Don't just disregard them because of their age. What they don't like, they don't like strangers, so tell them your name. They don't like loud noises. They don't like masks because they're scared to death of them. They don't know if you're trying to cover up something that you're hiding from them. Yeah, so we don't want to waste. Yeah. I'm trying to see. Somebody changed my slide. I'm glad they didn't change it any worse than that. All right, so don't waste your time in the interest of rapport. I get that, but make your time count. Get the story. Get what happened. Get the facts. You can do it quickly, but time is of interest. And I always said before, cellular death. Remember that? And I was trying to get everybody to understand what cellular death is. Cells make tissues and tissues make organs and organs make organ systems. But if your cells are dying, right, then there's a cost for that, right? And so if enough of those cells die, then you have tissue death and then worse. So know what your cost is, and I do. And so I always try to make it worth my time or worth whatever I'm doing. I always add that in like that. So some differences. Let's talk about some differences in adults first versus the pediatrics. Let's start with the airway. Let's talk about the tongue. The tongue is more proportionally larger in children than adults. 1 second. Here we go. Sorry. Their airways are smaller. Okay, and generally that's because their tongue is more proportionally larger. Okay, I don't agree. Lots of snot, maybe, maybe not. Teeth are soft, definitely. Their neck is very pliable, and that becomes a problem because you can't extend their head too far back. They are belly breathers, and nose breathers. We know that their abdominal organs are at risk because they are not protected. Cartilage and bone is still coming along, right? And their muscles are not developed yet in their abdomen, so their abdominal organs are at risk. Their head is proportionally larger, so if they fall, they usually like to fall right on their head. And that's for especially less than 3 years of age. Their airways are more narrow, and they do have more incidences of upper airway occlusions. Infants are very much nose breathers. Their tongue can become very deadly oral airway obstruction. And that narrow cricoid ring, and that's right where usually you'll find your airway obstructions. They'll usually be right there. I'm sorry, 1 second. I'm trying to get this to cooperate. All right, here we go. All right, so in kids less than 6, make sure that their nares are clear because they are big nasal breathers. You might have to assist children in coaching their respiratory rate, tell them to slow their breathing down. Not usually, though. I haven't had to do that. And yeah, most your airway adjuncts are going to be a little different because sometimes you kind of get in between sizes, and so it's just something that you have to deal with. Just you'll have to pick the correct size. Sometimes it's a little harder. Yeah, and I said it before, I'll say it again. Cardiac arrest begins as respiratory failure in pediatric patients almost 99.99% of the time, unless there's some type of inherited cardiac disease. Chest and lungs, so we have less muscle, which means we have less ATP, right? Less energy. Less muscle, meaning less protection. We talked about those abdominal muscles, they're still building. And, they have less compensation in accessory muscles, meaning once they burn through their accessory muscles in respiratory failure, when they're really working hard, they don't have that energy source, and they don't have that those muscles that are developed like an adult does to help them get that chest out and those lungs expanded. You're going to see the next slide, the same thing I already said. I've covered that. Extremities. Growth plates, right? So that can be a very serious fracture for a child to have a growth plate fracture. Okay, so below the head of long bones, or the bone growth lengthens. Okay, so that can present an IO issue as well. They're proportionally smaller, less skin. They have less body surface area. So if they have a burn, it's worse than because it covers more surface area. They don't have the fluid to lose. So if a child is having diarrhea, that's very bad, right? I mean, it can be life-threatening. So we got to make sure that kids stay hydrated. If they can't stay hydrated, they got to go to the hospital. They said, no, he's just vomiting, he'll be okay. No, he won't be okay. They do not have the fluid to spare. So if you have a kid that has a fever and vomiting and it's uncontrolled, this is not a 2 a.m. patient. Let me not tell you all the risk and consequences of this patient refusal. You have to tell them. There's been a lot of kids, and I'm not joking, that's died from being dehydrated. It's a serious matter. And that's right. So you have a child in respiratory distress. They will have an increased metabolism, but decreased reserves. They don't have the reserves that we have. Yeah, so they don't have that glycogen store, all right, and so they won't, if their body starts, if they become low on their blood sugar, they don't have glycogen to call upon, right? That they go straight to metabolic acidosis. Okay, they go straight to burning and eating muscle. Infants do not have the compensation to shiver when they're cold, so hypothermia is a big deal.
You must feed the fort.
I like that, whatever. All right. Your scene evaluation. Get your dispatch information. Comes in as, let's say it comes as a pediatric cardiac arrest. Stay calm. All right, get your mechanism of illness or injury. And get as much information from your caregiver and leave them there unless they are hysterical. So if they're awake on their initial assessment and normal, that's cool. That's a good sign. Then we can consider that patient critical or non-critical. So appearance here, we have mental status, muscle tone, members of the pediatric triangle, the circulation signs, skin signs, skin color, respiratory rate, respiratory effort. So that's work of breathing. That's what we're deciding, and we're deciding it rather quickly, and we want to know sick or not sick. Is the airway open? Is it patent? Can it be maintained? Can it be maintained with position? What about an adjunct? Can I suction that airway to make it open again? What do I have to do to maintain this airway? Those are decisions that need to be made very quickly. And that's why I like to find somebody competent on the scene if I have an airway emergency to deal with that as I continue. Now, I'm not going to go far. I'm going to look for breathing. All right. But we have got to have somebody on that airway. Breathing. So we're going to look, and that's key here. We're not going to, we're not going to look at the pulse ox to decide is the patient breathing. We're not going to do that. We want to know, do I have chest rise and fall, and is it adequate? Am I using accessory muscles to help? Is the patient using accessory muscles to breathe? Okay. A child that's all they're concentrating on is breathing is a very sick child. You need to auscultate, but absent breath sounds are terrible sound or terrible sign. All right, normal vital signs, you need to know those. You're not going to know what abnormal is if you don't know what normal is. Color, again, is this patient cyanotic, which is a late sign? Is this patient pale? Distal cyanosis means the patient's hypoperfusing. And if it's up around the core, then we're looking at respiratory issues. And then circulation, fast or slow. And if it's slow, start trying to correct your respiratory problem. Know what end organ perfusion means, right? You got to know what it means. Evaluate the skin, the kidneys, the brain. What are some bad signs? Well, a skin capillary refills that are less than 2 seconds can be a bad sign. Kidneys, if we're not putting out urine, that's a bad sign. If the brain is not responding, like central nervous system, motor sensory function, seizures, bad sign. So we're looking for respiratory rates that are greater than 60. We're looking for a heart rate that's greater than 180, less than 80 and 5 years of age. Heart rate less than 60 in a 5-year-old. Respiratory distress, trauma, burns. All of these are critical type incidents or signs. Cyanosis, sepsis, fever, seizures. Some specific medical emergencies, right? So infections, what kind? Maybe pneumonia. Okay, pneumonia. Maybe we're looking at some type of maybe a septic type infection secondary to appendicitis. We're looking for respiratory emergencies. The usual we encounter: asthmas, bronchitises. Neurological emergencies, although rare, it happens. The GI emergency. Now, the GI emergency could simply be vomiting. Okay, it could simply be gastritis. If that patient is dehydrated, secondary to diarrhea or vomiting or fever, all of those are serious conditions for a pediatric patient. And then poisoning. Okay, did they get into something, take some overdose of medications? So for infections, of course, we're looking for your fever, your chills, etc. Tachycardia from the fever, right? So here's your patient who's in, could be moderate distress. Okay, there's an increase in the work and breathing. Your ATP, though, remains adequate. Your respiratory rate around 30 or so, decreased CO2 slightly. Let's look at some distress signs. Well, we could talk about retractions, nasal flaring, okay, increased heart rate. we start talking about head bobbing, we start worrying that we're going to, when I call it knocking on failure's door. Head bobbing and grunts and central cyanosis, even though it improves with O2, are signs that you may be going down failure road. Okay, this is what I was telling you about earlier. I may not need to bag this patient right this second, but I may have to anticipate bagging them while en route to the hospital. Now we're at failure. So we have a high CO2 that's risen. Patient is acidotic and they're lethargic. We have retractions. Okay, we have muscle retractions. Our respiratory rate is slowing. That's not a good sign. We're going from 45 breaths per minute down to 32. Not good. Muscle tone we're losing muscle tone. We're getting tired. The patient is like, I don't know if you've experienced this yet, when somebody looks at you and says, I'm just too tired to breathe anymore. That's the worst thing that they can tell you. Anybody can tell you. That's when you got to have a plan. You better have a plan. This is a patient. If you don't do anything, will die. They may not die with you. They may die with you, but they most certainly are going to die in the ER unless you do something to stop that. Now we may get them back, all that, but may not. I don't know, but let's don't find out. Let's correct that now. Let's fix it now. What do we need to do? Let's start bagging the patient. Let's get a paramedic on there. Let's give some drugs. Let's get this patient's airway secured. Let's, put an ET tube down. Let's do some stuff. Let's do some AEMT paramedic stuff. And then arrest. So this is a patient who goes from 34 to 0 breaths per minute. It's a pretty obvious sign. They're no longer breathing. They're agonal. Maybe they're breathing 2 times per minute now. There's no chest rise or fall. They're very bradycardic. And they're fixing to be asystole, meaning asystolic, without contraction of the heart. Not a good day. Some upper airway emergencies to be aware of: croup, epiglottitis, and then bacterial tracheitis. Croup is viral. They say 6 months to 4 years of age. True. Peaks at 2 years of age. Okay. And perfect time for it to start happening now. Fall to winter. Okay. And so it's subglottic, below the glottic edema. Croup is not usually a life-threatening issue. It's easily treated if it does become that way. Usually we don't have to mix the racemic epi. Usually warm humidified. Usually like humidified. No, not humidified. Where am I getting this at? Saline that we will use to breathing treatment like that. Just regular saline. Okay. No big deal. Usually not a big deal. Okay. History of a mild cough. Then they'll start getting that harsh seal type barking cough. All right, remember this. This is croup. And now we're going to talk about epiglottitis here in a minute. No doubt there's going to be a question that you're going to differentiate between croup and something else. Okay, so this is what, it's where you need to know it so you can maybe save somebody's life one day. But maybe if you just want to pass a test, that'd be good too, right? So these patients don't usually drool. Okay? They're not drooling. And their fever is usually low. Not always in real world, but it's viral. Okay? So when you compare a fever from viral to bacteria, usually bacteria is going to have a higher fever. These patients can and do often have that inspiratory stridor noise, okay? Not to be confused with other childhood diseases that have inspiratory and expiratory stridor, okay? And then tracheal tugging or retractions. Position of comfort, cool mist of O2, IV, man, don't worry about IV. I mean, unless your patient has something else going on where they're dehydrated or something like that, then yeah, but usually you don't have to put the kids through it. It may make their croup worse. And here's epiglottitis, and there's always a comparison between croup and epiglottitis. So we do have it. They're both upper airway problems, edema to the epiglottis. We don't see it as much anymore because kids are vaccinated for this. Okay, so this is a sudden onset. Croup is a couple of day onset. Epiglottitis is they were doing great 30 minutes ago. Now they have this fever and they're drooling all over the place. There's the high fever, 102 to 104. Drooling, you don't drool with croup, you drool with epiglottitis, okay? And you're drooling because the throat, man, is so sore. You don't even want to swallow. And then that stridor is inspiratory and expiratory stridor. Okay, that stridor is that loud whistling noise because the airway is about to be closed off. Something you don't want to play with, not even paramedics, because you get about one shot at that airway. If you don't get it then, you won't ever get it because you'll start having vocal cord spasms and the airway will actually close off. That's the reason why we do not look in the throat to visualize. Okay, not unless you just don't, unless you just have to. You better have an AT tube in your hand if you're doing that. I hope I've never been in that situation. I hope never am. Be prepared to intubate if you have to. High pressure BVM with 2 people can work, but remember it's that upper airway swelling off. And needle cry, forget it. I don't care. Who tells you that they work? They don't. It may be as when you become a paramedic, you have to pick that as the only answer, but they don't work. Don't let anybody fool you. They don't work. It makes me angry when I see that as an option. I had to do it one time and it did not work. Bacterial tracheitis. So we know it's bacterial. So we would expect a fever, right? Infection to the subglottis, below the glottis. It's rare. Okay. History of croup maybe for the last few days. I don't even know if I've dealt with this ever. Inspiratory and expiratory stridor. There's no drooling, guys. I wouldn't expect to see this. If you ever do, though, there's no drooling. Watch the next slide say drooling. It doesn't. Blow by O2 and turn off the pop-off valve if your BVM uses one. Foreign body airway obstruction. And these are nasty, nasty days right here. It depends on what it is. Grapes, hot dogs, all these up here are the big ones. Balloons, coins. So if your patient is not moving air, you've got to deal with it. If your patient's still coughing or moving air, leave it alone. Leave it alone. Get a paramedic there in case it goes bad. But other than that, just leave it alone. And don't upset the patient. That's when you go, hey, I'm not touching you at all. Not going to touch you at all. We're just riding to the hospital. So then we talk about the lower airway emergencies, and these are your common ones, your asthma, bronchitis, pneumonias. Okay? I'll get to that in a second. I'll have to see what that means there. Foreign body airway obstruction is usually upper airway. but we'll entertain it for a minute till we get over there. So your asthmas, we know what that is, right? We know that we have bronchial constriction. Okay, we know that one. Bronchiolitis is a different one. It's not bronchitis, it's bronchiolitis, right? And so I don't know if you guys remember, but I was talking about it a while back. I said, when you have your bronchioles, you have your bronchus, your bronchioles, and your bronchiolas, and then when you're at those bronchiolas, that you don't have smooth muscle. They're not smooth muscle, so you can give albuterol all day long, and it will not work. It will not cause those to dilate. Okay, and that's the problem. You'll treat these patients and you will, because I would. You're going to treat them as if they're asthma. Okay, but they're not going to respond. Okay, and so we need other medications, and I don't really think there's a whole lot of out there for it. Then we have pneumonia. Let's compare pneumonia to asthma. Pneumonia, man, before COVID, we could say it was mostly bacteria, but thanks to good old COVID, we see a lot of viral pneumonia right now. But you usually will have a much larger, much higher fever with pneumonia. You'll be more malicious. You'll basically all the symptoms of sepsis you're going to see with the pneumonia, as opposed to your asthmas, right? You're going to have Rales rhonchi with pneumonia. With asthma, you're going to be dealing with wheezing. And let's just fly through here real quick. 50% of asthmas, okay, less than 10 years of age. I'm not testing you on that. Genetic, absolutely. Bronchial spasms, yep. And then your triggers, right? So it could be environmental. So you have your allergens, and then you have those who are triggered by stress. Phase 1, phase 2. Phase 1 is when you have your bronchial constrict, a histamine release. That's going to cause your bronchial constriction is from your histamine. And your beta 2 agonist, one heart, two lungs, beta 2, albuterol, can be effective. Phase 2, this is when we have, not only do we have the constriction, but we have the inflammation. Again, that is your histamines are getting fired up right now. And not only are they causing your inflammation too, but then your beta 2s don't work as well because they don't deal with that inflammation very well. Okay, this is when you have your mucus plugging, and that's what atelectasis is, and that's where the lung stops stretching and stops, that tissue really stops becoming less cooperative. Okay, and then we have steroids. We need those steroids for that. Status asthmaticus. This is a prolonged attack, guys. This is ones that we just can't turn around. Where albuterol, Atrovent, Solumedrol, MAG, and it's just continuous. Okay, and so these are paramedic drugs here. Don't worry about it. Don't worry about it. I know we're over 30 minutes at this point. Let me see where we're at. I think we're getting close to being done, I hope. Nope, we're not. So I'm going to do a part 3. I will do a part 3. So keep your attention span. Take a break, come back and listen to part 3, and we will have that for you very shortly.